Patient coming with the scrotal mass. On examination, it looks to be a testicular mass and it is indurated. Now, when when the mass is indurated, you have to see whether it is a non-tender or tender. If it is non-tender, then you have to have a high suspicion of testicular tumor. And if it is tender, then it goes in favor of epidermolysis. Practically, in clinical practice, epidermolysis is much more common than testicular tumor. That's why it is very important to see whether it is a non-tender or tender. If it is tender, think about epidermolysis. There is no question of thinking about the tumor. Next comes what investigation you will do. First investigation will be ultrasound scrotum. Second investigation is blood test. That will be beta HCG, alpha fetoprotein, and alkaline phosphatase. Among the investigation, the most important thing comes that you cannot have the FNAC or biopsy from the scrotal area. Whenever you see a lump and that is indurated, you always think about taking biopsy or FNAC from that area. But in this condition, first and most important thing is that you cannot take FNAC or biopsy from the scrotal area because it will open up the new lymphatic channels for tumor spread. Because the testis origin from the para-aortic area or pre-aortic area, because the site of the origin, and the scrotum drains into the inguinal lymph node. Testis drains into the para-aortic or pre-aortic area lymph nodes, and the scrotum drains into the inguinal lymph nodes. When you take the biopsy from the scrotal area, tumor spreads into the inguinal lymph node also along with the para-aortic, pre-aortic area. So the orchidectomy in this condition through the scrotal skin will upgrade the stage of the tumor and it will harm the patient greatly.